Okay, good afternoon, everybody. Welcome to this public forum on varicose veins from exploration to management. Appreciate all of you taking time in your busy day to learn more about varicose veins. My name is Chong Zitek. I'm a vascular surgeon at Singapore General Hospital, and I'm glad to be your host today. We also thank the Patient Liaison Service and the office for bringing this entire webinar to you. I'm going to start by sharing my screen. Okay, I trust you can see my screen and hear me. It's great that we have a big sign up today. More than 1,400 of you have expressed interest. And it's great that we already have some questions in the Q&A section. During the talk, please feel free to put in your questions and we'll try to answer as many of those questions as possible at the end of this. I'll try to finish with some time for Q&A section. Okay, we'll start with a little introduction about myself. I spent some time in Australia with my medical school and internship, subsequently spent another 12 years in the US at different hospitals, including Johns Hopkins and Brigham and Women's Hospital, and got my first job over there in the US. Subsequently, I came back to SGH in 2012, so now a little more than 11 years ago, and became the head of department in 2015. Our department is now 9 surgeons strong. We're the only and the biggest department of vascular surgery in Singapore, and I'm glad to be here working with my colleagues to help you with your vascular conditions. 2 years ago, I was also appointed head of the SingHealth Tube Disease Center. So we take care of all vascular diseases within SingHealth. So that includes Changi Hospital and Sengkang Hospital as well. In my free time, this is what I like to do. When I was living overseas, I like some winter sports. In Singapore, I play tennis in the weekends to help de-stress. And then I like to take pictures when possible. Okay, this is the outline of our presentation for today. I'm going to introduce the concept of venous insufficiency, what varicose veins are, and how they affect you. We'll talk briefly also about how we diagnose the conditions that may be associated with venous diseases. We'll go through what kind of signs and symptoms typical patients may have and feel that would lead them to seek treatment. To follow that, we'll talk about the management and treatment options, all the way from conservative management to invasive therapy and medical therapy. At the end, I have a patient video which was taken pre-COVID now of a patient that had venous treatment and her journey in the medical system. As mentioned, we'll talk about the Q&A and try to answer as many questions that you have about this condition. Okay, so first we'll start with varicose veins. This is a very common term, and they are these twisted large veins near the surface of the skin. You know them when you see them, and most commonly they develop in the legs. We can have it in other parts of the body as well, but we are concerned with the legs at this time. Very often they are misunderstood as simply a cosmetic issue, and definitely many decades ago, that was the viewpoint. Today, there's more awareness of this condition, and especially the serious one called chronic venous insufficiency. The worldwide prevalence of chronic venous insufficiency is quite large, estimated at 20% of the general population. It's 10 times more prevalent than peripheral arterial disease, and that probably gains more attention worldwide. CVI can affect all age groups as well as men and women. Without treatment, these could progress to a serious medical condition. So the vast majority of patients with venous disorders remain undiagnosed and untreated. A little bit of lack of awareness, a little bit of maybe the initial medical point of contact, not recognizing it as a condition that needs diagnosis and treatment. If you look at the prevalence by age and gender, you can see that both male and females have this problem. It is true that females have it more commonly, and it is more prevalent as we get older. This is a video.
The deep veins run between the muscles of the legs. Contractions of these muscles, when you move your legs and ankles, help to squeeze the blood back up towards your heart. Veins also have valves that prevent the blood from flowing back towards your feet. Here we show a valve and the muscles around the vein. Varicose veins are thought to develop when the valves don't close properly. Here we show a valve in a superficial leg vein. If the valves don't work properly, the blood is able to flow backwards. Blood pools in the vein, causing the vein to stretch. This is called a varicose vein. Here we show a vein that has become varicose. Here we show a varicose vein in the lower leg. Varicose veins may cause symptoms such as aching, itchiness, or swelling of the ankles. The deep veins run between.
Okay, so hope you managed to see that video. I think it just helps to introduce the concept of vein valves. They're present in our veins and they help prevent reflux, which is what the blood will naturally do given the effects of gravity, going downwards, down into the ankle region. As most of us spend a lot of time standing up, we would like the blood flow to go towards the heart. The next picture shows muscle contraction in the calf muscle in particular, and this is always good to force the blood up towards the heart. This is a little bit of physiology. As we are lying down, our vein pressure in the ankle is low. However, as we stand, the pressure increases, and this is a function of your height. So the level of your heart to the ankle, roughly about 90 millimeters mercury. But when you walk, because of the calf muscle pumps, it decreases the pressure greatly. This is also a point where I remind everybody that has been standing for a long time or maybe sitting for a long time to stand up, walk around a bit, and after 7 steps, the calf muscle pumps will work and you can reduce the pressure in your veins. This is showing graphically what happens. The blue represents the vein pressure in the ankle. So as we lie down, it's very low. When you're sleeping at night, it's very low. When you stand, it rises to 90 millimeters mercury, roughly, for an average sized person. But when we walk, we activate the calf muscle pumps and the pressure decreases dramatically. As we stand still again, it increases. This is in a normal system where the valves work. In an abnormal system, you can see over here, the process is the same when we lie down, but when we walk, because the valves are defective, the pressure doesn't decrease to as low as if the valves were effective. And the difference you can see is roughly 40 millimeters mercury. And if you keep that figure in mind, that is what the effect of the compression hosiery or compression socks, compression stockings help with the 40 millimeters mercury as we stand for a long period of time. There are many occupations that require standing, including sales, physicians, nurses, teachers. So many of these occupations require long standing, and this sometimes can be aided by compression. Now we move on to diagnosis. How do we pick up chronic venous insufficiency or venous reflux? Not with any X-rays or CT scans, but a duplex ultrasound, as you can see in the left picture. It's done with the patient standing up on a stool or pedestal, and then using the ultrasound, which is non-invasive, no radiation, you check the direction of blood flow to see when the patient stands if there is reflux. An example of a normal scan is in the middle picture, where you can see we check for deep venous thrombosis or blood clots in the deep veins, and there are none. We then look at the direction of flow in the superficial veins, and the vein on the right side is the great saphenous vein, and the direction of flow is normal, as in towards the heart, so there is no reflux. If you contrast that with the picture on the right, you can see again the deep system is pretty normal, but the superficial vein, which is the great saphenous vein that runs on the inner surface of your thigh, and it's deep, so you may not be able to see it, is large. And the direction of flow is towards the leg, which is incorrect. The vein is also large here at 15 millimeters. A normal sized vein, we would say, averages 3 millimeters. So this patient has had reflux for likely a long period of time, maybe decades. There are also large varicoses we can see in the picture below. So what would these patients feel and see? They can see visually varicose veins, usually around the knee region on the inside of your leg. They may also see some ankle swelling or feel the sensation of swelling, worse at the end of the day, worse after a long day standing. Their legs feel heavy and tired, requiring them to put their feet up. I know all of us want to put our feet up at the end of a long day, but in patients with venous insufficiency, this is especially worse. They may also feel some aching or cramping, some burning, itching, restless legs. This may lead to skin changes, which I'll go through in a little bit. And lastly, if they're not treated for a long time, lead to open wounds, such as venous ulcers. This is a classification system called the CEAP classification. We'll just go through the C, which starts with no visible disease, spider veins, and all the way to ulcers. And as we go higher up the C classification to C6, there is increased pain and reduced quality of life. This is something that we pay particular attention to, the quality of life for these patients. So I'll go through the C system. This is in a bone vein study done several years ago now, looking at the prevalence of venous disease. The most prevalent is spider veins. All of us have spider veins if you stare hard enough at your legs. And as we get older, we get more and more of these. This is what's shown on the picture. Sometimes they're a little bit more red, and sometimes they may be cyclical. Now we also have next C2 disease, which are varicose veins. These are obviously very pronounced. Some of our patients have such pronounced veins. A lot of them, for example, are food sellers that have been selling food for decades and standing for a long time, may come in dragged in by their children or even grandchildren after many decades, and they may be large veins. Otherwise, some patients may have much smaller veins, but also varicose. They may come in with swelling, otherwise known as edema, and you can see that the ankles are the areas that are easily picked up for foot swelling. They may also have skin changes, especially around the inside ankle area, which is quite common in these patients. This prevalence, you can see, is the incidence is less and less as we get to C5 and C6. There's also evidence of infection here, cellulitis, quite a common problem due to the swelling, as well as hyperpigmentation, where the skin changes color, usually a darkening of the skin. Patients may also have healed ulcers when they come to see us, as you can see in the shiny scar that is on the picture over there. And last but not least is the venous ulcer, which is active. And this is what we really try to minimize. And if we see it, try to heal them as much as possible, as fast as possible, because this is severely debilitating, and a chronic wound is never good for the body with inflammation. I'll go through quickly the current evidence-based guidelines from EU as well as America. This is excerpt from the publication in 2022 on the guidelines of management of chronic venous disease. And class 1 guidelines are the highest level of evidence. So it suggests that we need treatment of patients with symptomatic varicose veins, reinforcing the point that varicose veins are not just cosmetic, especially if they're symptomatic. It also talks about those patients with venous ulcers. A lot of time, there is a little bit of neglect, and we hope they will go away. Hoping alone is not good enough. We need early endovenous ablation, and I'll go through that term later on in the presentation. It also talks about for those with healed venous ulcers to have treatment, not because it's healed, but we want to reduce the recurrence probability of the ulcer. Class 2A recommendations, I'll go through it at another time. This is from the US. This is from the Society of Vascular Surgery in conjunction with the American Vein and Lymphatic Clinical Practice Guidelines. And it's a very lengthy document, but I'll just summarize 2 points. Point 1 is that duplex ultrasound, which I've talked about briefly just now, is the diagnostic test of choice to evaluate venous reflux. The second point is for patients with symptomatic reflux who are candidates for intervention, then they should have intervention rather than long-term compression stockings. In the past, we've always said they're equivalent, but the guidelines now have shifted the balance to early intervention rather than compression stockings. So then let me now go through the treatment options. And first one will be the conservative therapies. Exercise is always good for us. We activate the calf muscle pons. Leg elevation is great, but sometimes our jobs require us to stand. If you hang upside down like a bat, you're not going to have varicose veins, but that's often difficult for most of us. And we'll talk about compression garments next. So this is for venous ulcers. C6 disease, you remember the CEAP classification. It's a multi-layer, either 2 or 4 layer bandage that gives pressure to the area so that we heal the ulcer as soon as possible. However, you can imagine this is not very comfortable, and in hot and humid Singapore, it's certainly not very tolerable. So we try to find other options. This is compression stockings, and this is just a slide from one of the companies. This is a German company, so it's all in German, and I'll go through this in more detail. So this recommendation is at least 15 millimeters mercury of compression at the ankle level. We want more compression at the ankle and less compression towards the thigh so that we can so-called milk the blood flow back up to the heart. For patients with more severe disease, you want 20 to 40 millimeters mercury at the ankle. Remember previously I showed you the graph of a normal patient and a patient with venous insufficiency, showing that the difference was about 40 millimeters mercury. And this is why for severe disease, we want at least 40 millimeters mercury at the ankle. The picture just shows a typical compression sock that you can buy from the internet. So for venous ulceration, though, we need to have compression like I showed you. This is a weekly or twice weekly dressing, not comfortable, but it is to achieve the pressures that are required to heal the ulcers. Oftentimes, this takes several weeks, combined with medication to achieve the maximal chance of ulcer healing. So we go back to compression stockings, and the main thing is the fit. So compression stockings are always tight. There are different varieties, as you can see over here. And for the men, I try not to use the word stockings. Nobody likes to wear stockings. They wear socks. So they can look like business socks. Nobody knows what you're wearing. They come with a dark color and they go up to the knee. But for the prescription ones, the important thing is that it gives more support at the ankle level, less support towards the thigh, as I mentioned. So it's graduated. And also, it needs to be tight. So for a lot of patients mention that it's very tight. It's tight for a reason. If it were loose, it will not work. This was something that we looked at now a few years ago, so the prices may not be accurate anymore. But to give an example of medical grade compression stockings, they are not cheap for sure, but they may be better quality. And so we try to improve compliance by explaining to the patients why we need them. Also, it's difficult to wear these compression stockings past the ankle and the knee joint, and they are aids to help. This is particularly so for our older population who may have some arthritis, and it's difficult to put on those stockings. So these are an example of an aid that can help you put on the stockings more easily than just with your bare hands alone. Next, we'll go on to medical therapy. What are the medications that are used? The most popular would be Deflon. This can be bought. This is a Watson's screenshot. I'm not sure if the price has changed, but it is like a vitamin for the veins. Doesn't require a prescription. It's available at your local and online store, and it can help with some of the symptoms. I'll go through the science of Deflon. This is looking at the Cochrane Library, which is a very high-level database of systematic reviews, a very high-level evidence in the medical literature. And it looks at swelling, pain, cramps, heaviness, and there is a potential benefit for use of Deflon. So this is probably something that you can try first line to use Deflon for your varicose vein symptoms if desired. So these are the categories that may improve with this medication. The side effects are also very low. However, there is no benefit for venous ulcer healing. So good for the symptoms, but doesn't help ulcer healing time. Next, we move on to the interventional treatment. Radiofrequency ablation is something that was very popular and continues to be very popular in Singapore and around the world. A lot of patients also hear about laser veins. Laser is definitely still one of the cornerstones of treatment and remains popular today. And I'll go through these endovenous thermal ablation techniques. So this is an example of the system used for ablation. Ablation is just a fancy word that uses heat to damage tissue, which makes scar. So the scars close the vein. And the energy can be in the form of radiofrequency, as shown in this slide, or laser, which is also used quite frequently. This energy is delivered through a catheter heating element, and then it causes damage to the vein wall collagen and structures to close off the vein so that there is no more reflux. This is a minimally invasive technique using local anesthesia, so patients can be awake during the procedure, and it is done as day surgery. I'll go historically to open vein surgery. This was done quite a bit in the decades past. We still do a little bit of it now, mainly in the form of phlebectomy, but not much in the form of stripping. So this is stripping and high ligation we use to make a cut in the groin. And because this vein lies on the inside of the thigh all the way from the groin to the ankle, you can physically remove it. This is also the same vein, out of interest, for cardiac surgery, where they do the bypass for coronary artery bypass graft or cabbage procedures. The stripping obviously is a very effective procedure because the whole vein is removed. However, as you can imagine, this is quite painful. This requires general anesthesia and usually overnight stay, at least in the hospital. We don't tend to do a lot of this now, but sometimes we still do that. Next, we look at the newest forms of therapy, which is non-thermal, so no heat to injure the vein, and doesn't require tumescent anesthesia, which is required in point number 3, thermal ablation, where we need to numb the area around the vein so that the patients can tolerate. And there are a couple of different ones. I'll talk about sclerotherapy, mechanical sclerotherapy, as well as cyanoacrylate or superglue adhesive ablation. This is a video I'm going to show you for spider veins. So these are what spider veins may look like. Sterilize the area, clean it up and use a very small needle as shown over here in the yellow. Go just a little bit under the skin and inject a sclerosant. You can see that the vein wall, the blood is displaced by the sclerosant and it sort of magically disappears. Obviously, this video is really impressive. And there may be a little bit of redness afterwards, up to 6 weeks after sclerosant. There is really no magic here, but the appearance of these veins can be improved. Spider veins, as I mentioned, is C1, so it is more on the cosmetic side rather than medically causing symptoms, but this is one option. Next, I'm going to talk about this non-thermal, non-tumescent system, which currently the venous seal system is what we use a lot of. It's by Medtronic, one of the large medical companies, and it is sort of a super glue. The medical term is cyanoacrylate. The acrylate component is similar to the nail polish that the ladies may use to do up their nails. So it is a simple solution where there is a gun to deliver the adhesive at 0.1 cc's per push. There is no worry about injuring surrounding nerves because there is no heat injury. And the important thing is not having to wear compression stockings, which is a big plus for the majority of our patients given our hot and humid climate. I put this slide together when there's more than 1,000 cases, but we've done more than 2,000 cases now at Singapore General Hospital. This was a profile picture in 2017 showing the technique. Then we adopted this since 2016, and this was an article in the Straits Times. So let me show you the procedure animation. So this the equipment. This is 5 cc's of the glue, and this is a proprietary trademark cleared by our HSA so that we can use on our patients. We cannulate the vein under duplex ultrasound somewhere in the knee or below the knee area. It's a small poke like taking blood. We then advance the catheter close to the groin. It says 5 centimeters from the SFJ or groin. This is all done under duplex. And then we compress the vein so that the adhesive or the super glue doesn't go up into the deep veins and cause a problem. We then use manual compression to seal the vein. So there is no heat involved to seal the vein here. It is just manual compression and the super glue. And like the super glue, it cures pretty fast. So at the top, we need 3 minutes for compression. Subsequent 3 centimeters will be 30 seconds. So if you calculate the time, it's a short, less than 1 hour procedure before the procedure is finally complete. And the patient leaves with a small band-aid for the ablation of this. So it is a minimally invasive procedure. Patients can go home the same day, have local anesthesia, and in general, they are quite satisfied with the outcomes. So I'll stop here. Let me show you some clinical results. These are various studies, including those from first in human, that from Europe, and then in US. And the bottom line picture is that at 5 years, the efficacy rate as a defined treatment success is 93.6%. So this is a highly successful procedure. There is, of course, recurrence in every single modality. However, it is considered quite good given the minimally invasive option here. So 5 years data. At SGH, we also published our 3-year data also showing high levels of patient satisfaction and high efficacy as well. So from the patient standpoint, this is day surgery, no need for compression stockings, and we confirm via ultrasound that there is no more reflux at the end of the procedure, and it is the newest therapy at this point. So immediately post-procedure, these are actual patients of mine, and you can see I treat all the way down to the ankle in some patients, and otherwise in some patients, we treat just below the knee, and you don't have a large scar. Now, pre-procedure, these are some pictures of large varicose veins. The main aim of the procedure is to relieve the symptoms of the patient and not just cosmetic. However, there is a side effect sometimes where the cosmetic appearance as seen over here is also improved after the treatment of the GSV reflux at the groin level. Let me show you a patient video of the experience.
It was just a constant reminder of that something was wrong, and it was very frustrating because I wasn't sure what was going on. Yeah, so my name is Filippa. I'm 30 years old. I have lived in Singapore since 2014. I love being outdoors, exercise, running in particular. I used to go for hikes. That's basically how I spend my free time. I think about 2 years ago, I realized that something was wrong with my leg and I wasn't sure what it was. So the leg was swollen, it was aching a lot, and I had these pins and needles quite often. And close to my ankle, it was almost like a spider web, so it was hard to walk. Yeah, just very uncomfortable, like always. So it stopped me from running, and instead I started to walk, but it didn't go away despite that. But I couldn't run, and most of the exercise that I love doing, I had to stop doing that. I did seek treatment quite a few times, both in Sweden and in Singapore, but the doctors told me that it was probably water retention. It was actually it was unbearable after a while because it prevented me from living the lifestyle I was used to, and I was worried it was something bigger than just water retention. I went to see a doctor who did an ultrasound, and he then referred me to Professor Chong. And then I had a day surgery. All went very smooth. And now I can run again. I'm outdoors more often. I don't have to worry about what I wear. And again, like the pressure on my leg and on my foot especially, it's just gone. So it feels like I can, move like properly again. I'm very grateful for that we could identify that this was a chronic venous insufficiency. Well, I am doing the things that I used to do, which I haven't been doing for 2 years. So I'm running a lot. I'm out going for hikes and spending most of my time outdoors.
Sorry, I muted. So that was a patient of mine, Filippa, who had a good experience, and very pleased that we're able to help her, and wanted to have her articulate her actual journey through our department as well. So we have 9 surgeons in the department, and they're all very skilled in the treatment of all arterial and venous as well as lymphatic diseases. And they're here, and we're all here to help you with any problems that you have. So I think with this, I'm going to stop and be happy to go with the Q&A segment. We want to try to make sure we stay within time. Feel free to put in questions and input them. Okay, so the first question is, how do we tell if veins are varicose or not? So we have veins in our body. They are inbuilt into our system, in our legs and in our hands. And if you look at the back of your hand, you can actually see those veins. Those are pretty much normal. They are varicose when they are large, they are bulgy, and sometimes people describe them as ropes or snakes. They happen more often in the back of the calf area, as well on the inside around the knee. These are common areas where you can find varicose veins. Now, varicose veins are just a description. Not all varicose veins need treatment. Treatment will only be required if there are symptoms associated with heaviness of the leg, some aches on long-standing, itchiness, swelling, and of course, what we talked about, which are venous ulcers. So with those, then varicose veins need to be treated. As we stand for longer and as we get older, we all have some varicose veins and spider veins if we stay hard enough. So not all of them require treatment. Only those with symptoms require further evaluation and possible treatment. Thank you for the question. So the next question is genetics. The truth is that if you can choose your parents, you should do well, but unfortunately we can't. So it is true that many people with large varicose veins also have a family member, sometimes an aunt or uncle with large varicose veins as well. Genetics do play a part, but this is not something we can change. What we can change is, if required, early diagnosis and treatment, and also support in the form of compression therapy. For those of us that are in jobs that require long-standing, even from a younger age, we can consider wearing compression socks. I sometimes wear them when I'm in the operating room for the whole day, and it does help with the heaviness, which is typical after a long day. So genetics play a role, but not much we can do to change that, not as of now. Maybe in the future where we have the ability to change our genetics. So this next question is, do veins appear more protruded due to aging or health conditions? Or do we need to be cautious if that require medical attention? I think this is quite similar to question number 1, where we talk about varicose veins. These can become protruded, and yes, as we age, we do have more varicose veins or larger veins, probably because of cumulative long-standing and pressure on the veins. And it can represent chronic venous insufficiency or venous reflux. So this could be a sign of more serious condition, but not always. As mentioned, we normally go guided by the patient's symptoms of any discomfort, uneasiness, aches, and heaviness, rather than the sole appearance of the veins. So appearance alone is not going to be enough to warrant treatment or further evaluation, but coupled together with signs and symptoms, then we can think about possible evaluations. If there's any worry, of course, you can engage with your medical provider, and then we can evaluate further from there. So the next question is it true that crossing legs lead to varicose veins? I don't have any evidence that crossing legs lead to varicose veins. I think crossing legs sometimes can lead to some joint pain. Certainly, it doesn't really lead to varicose veins. So I don't think that is correct. Maybe an urban legend. Will lifting weights worsen venous insufficiency? Certainly, for those that go to the gym a lot, they have large muscles and large veins. I think this is quite a common sight. This is because they work out their muscles a lot, and so the blood flow to the muscle to allow for the activity is increased, and correspondingly, the blood return must also increase. So those veins are more highly developed. That's quite normal. It may worsen insufficiency if there is excessive pressure on those veins, but again, there is no data. But going to the gym, exercise, all of these are still highly encouraged because we develop the calf muscle pump, and they can help bring blood back to the heart against the direction of gravity. So I wouldn't say that we shouldn't lift weights because of the worry of varicose veins. Thank you for the question. So this next question is whether it's safe to engage in massage if you have varicose veins or chronic venous insufficiency. So first thing to remember is that for venous disorders, when you're lying flat, when you're lying down, the vein pressure is very low. Most of the time, as I understand it, massage is when you're lying down. So there's no contraindication or no worry about having a massage if you have varicose veins. The varicose veins and the muscles that are affected during the massage are different, and definitely there is no reason why you cannot have a massage when you have varicose veins. There's no issue at all. Of course, if you have a venous ulcer, which is a break in the skin, then that's different because it is painful if you touch the area, and then we're trying to also prevent infection. So staying away from the area is important. Yeah, but for regular people having varicose veins, there is no problem with massage. So please go ahead. Our next question is from a participant who has had a TKR. So that is a total knee replacement. It's an orthopedic procedure where the knee joint is replaced, usually because of osteoarthritis or wear and tear of the knee joint. So it's good that you're recovering now, but you can see some varicose veins. So I think, the main thing is to continue the recovery and the rehab with the total knee replacement, because that is very important. And we do see veins because surgery has been performed. And I think for a small area, there is no great need to do anything. For a knee operation, sometimes you are given a knee guard to wear. Those are sports kind of knee guards, which is just centered on the knee joint. This could be something you can wear, and this could also give compression and support to that particular vein that you're worried about, and could decrease its size and thereby limiting the symptoms that could come up from that varicose vein. So I don't think, based on what you're telling me, you need actual treatment for the varicose vein. You see it. I know it can be a bit bothersome, but focusing on the rehabilitation of the knee replacement, getting you back to where you were before the knee operation, and hopefully walking even more than before that, and then wearing the knee guard may be all that is required in your case. Thanks. So the next question is, after varicose vein treatment, how to take care of the legs so that you avoid recurrence. So the efficacy rate for example, venous seal treatment, which is the cyanoacrylate superglue treatment, at 5 years in the data is 93.6%. So there is a very good outcome after 5 years. Obviously, we would like it to be forever a lifetime. And to minimize recurrence, it will be to minimize long-standing, or at least have compression during long-standing. But that's not always possible. So I would say the treatments are now designed to allow you to engage in whatever active lifestyle that you want to engage in, and not have to worry about it. If the time comes and unfortunately there's a recurrence, it can be retreated again. The good thing that is minimally invasive. However, there's no sure fail-safe way of preventing recurrence. So compression is what may be required to minimize the chance of recurrence, minimizing the pressure in the legs. Thanks. So this next question is from one of our participants who has heard about lipodermatosclerosis, which is a condition where the area usually around the inside of the ankle is a little bit darkened and thickened, and there could be some scar tissue in that area, and the elasticity of the skin may be compromised. So that is a very different condition than varicose veins, although they can be both associated with each other. Long-term venous reflux, venous hypertension can lead to lipodermatosclerosis, as you correctly pointed out. And varicose veins could also be seen as a result of long-term chronic venous insufficiency. It's a good question. Next question is, can wearing compression socks reduce varicose veins? Yes, compression socks definitely help reduce the venous pressure, especially around the ankle area and other areas as well. And this could reduce the chance of formation of varicose veins. However, this may not be possible in everybody in every situation. For example, if you are in a job where you may be in an environment that may get your feet or your legs wet, then wearing compression socks may not work well. Also, in Singapore, a lot of us like to wear sandals or slippers out, and wearing varicose vein compression stockings may not be so easy with the sandals. Now, the next question is a common misconception. So wearing compression stockings when we sleep is definitely not required. In fact, when we are lying down, the pressure in the veins are quite low, 10 millimeters mercury or less, because it's at the level of the heart. So certainly, I don't think we need to wear compression stockings when we sleep. Of course, if that makes you feel better and you like wearing it, it's no trouble at all, and it doesn't do anything bad, unless you have any arterial problems. But compression stockings is not required when we sleep. It is only required in the daytime, especially during long standing. The longer we wear them during long standing, the better the effect. So there is no cut-off time, but most patients would wear them after they wake up in the morning, after they moisturize their legs, if they take a shower, then after the shower. And then at the end of the day, when they shower, they take it off and they stop it for the rest of the night. Now, compression stockings, like any socks that we wear or stockings, will get loose over time. In the 6-9 months, if you take care of it well, when they get loose, they need to be changed, because we need to maintain the pressure so that it is effective. So the compression stockings should be changed at least yearly, especially if it's worn daily. Next question. So this question is from a viewer who sounds like you have spider veins, so fine spider or reticular veins in the thighs. They don't cause any discomfort, which is great. There are measures which mostly would include compression therapy in terms of preventing them from getting worse. However, nothing needs to be done, as you correctly pointed out, because they don't cause any symptoms. So our aim is not solely cosmetic, where we remove all varicose veins or spider veins or telangiectasias or reticular veins, but our aim is to reduce the discomfort if there's any due to varicose veins or chronic venous insufficiency. So for you, we do not need to do anything more than if you like to wear compression hosiery for greater support, especially during long standing. Thanks. So this question is from a viewer about what kind of exercise is good for this condition. So in general, exercise is good because it increases your heart rate, it keeps your blood flowing, it's good for your cardiovascular fitness, and generally good for health. So I would say that there is no particularly good exercise for varicose veins. We don't have a particular varicose vein exercise. Exercise in general is good. And you should continue exercise. Activating the calf muscles, in particular for the lower legs, will be good to bring blood back to the heart and decrease the pressure in the veins, especially around the ankle. So no particular exercise for varicose veins alone, but exercise generally is good and should be encouraged. Thanks for the question. I note that we do have more than 99 questions in the Q&A. We'll try to get through many of those, but apologize in advance if we can't go through all of the questions. So the next question would be, can cycling and working out using elliptical, I believe, would be what you're referring to, help with varicose veins? Yes, any kind of exercise is a good idea for general body health. It doesn't in particular help with varicose veins. There are people who use compression therapy to help with the post-workout recovery, but a side effect of that also helps with varicose veins because it's compression. So using the elliptical machine is okay. Please continue with that regimen if you like it. Not specific to varicose veins, but good exercise in general. Next question, please. Next question is on alternative medical therapy, acupuncture, infrared, I believe, light therapy. So acupuncture has been shown to be effective, in particular with pain management. And if that's bothering you, please continue. In particular for varicose veins, I am not aware of any studies that look specifically on varicose veins, and I'm not sure that it helps varicose veins, although it potentially could. So I wouldn't say don't go for it, whatever that relieves your symptoms, if you have any. Now, in terms of light therapy, there are also different kinds of lights and lasers that have purported benefits on skin health, as well as reducing fine spider veins. And that is also used for actually treatment, especially in maybe more sensitive areas like the face. So I think it depends on the type of light, the wavelength, as well as the use of it. So I do not use that. My dermatology colleagues use that more for cosmetic purposes. So not for varicose veins, but maybe for fine spider veins that may offer an alternative. But I'm not the right person to comment, so I wouldn't give you any definitive answer there. Thanks. So the next question is on treatment recommended for spider veins. Okay, so I think there's a lot of interest in spider veins. The video I showed you is showing how injection sclerotherapy can help with spider veins. Spider veins in general are more of a cosmetic concern. We do get these as we age, and definitely you can find them if you look hard enough at your legs. So if there are spider veins and there is no heaviness, no aches on long standing, actually there is no need for treatment. And I would say in general, for the majority of spider veins, there is no medical indication for treatment, although I can understand that cosmetically it does not look pleasing. So for spider veins, the two more commonly performed treatments will be injection sclerotherapy you saw in the video versus laser treatment. These are the two that are sometimes done for it. Next question. So the next question is on cramps and stiffness in the calf muscle. Are they related to varicose veins? So unfortunately, many of us do suffer from cramps. Sometimes it's in the daytime, sometimes it's at night, sometimes associated with restless legs. These can be due to a lot of factors and not just varicose veins alone. Although sometimes some of my patients tell me that after treatment of their venous reflux, for those who have venous reflux, it improves their leg cramps. I'm not particularly familiar with the physiology behind that. So I wouldn't say that all leg cramps are due to varicose veins. And I'm not sure there is a good correlation between leg cramps and varicose veins. So this is something that is quite nebulous, but many of our listeners and their family members may suffer from leg cramps, and that may be not related to varicose veins. Thank you for the question. So our next listener has a question about MediShield or insurance typically cover the endovenous thermal ablation treatments. So actually our Ministry of Health is quite forward-looking in this. For us, we have a lot of patients who are using their insurance, and we can use insurance, especially when there is documented venous reflux and symptoms. So then it becomes a medical condition and not a cosmetic condition. And certainly then the treatment offered, especially in public institutions, can be allowed based on the claim limits of your insurance. This procedure is done as day surgery. Sometimes patients are concerned that they bought a hospitalization plan and require overnight stay or a certain length of time where they stay. Most insurance plans now are quite flexible, and they realize that for surgery procedure, you do not need to stay in hospital. So it's good to check with your insurance agent if you have such concerns, but the majority of insurance should allow these kind of medical treatments, since, as mentioned, this is a medical and not a cosmetic procedure. Good question. Thank you. So it seems that we've come to the end of the majority of the questions. I apologize that we cannot answer all the questions directly, but hopefully some parts of your queries have been covered. So I think it's now just about the hour. Thank you to all of you for joining. We have more than 600 participants. Thank you for all the questions. I hope this was a meaningful time you spent learning more about varicose veins. All right, have a good afternoon, and thank you for joining the webinar.